Hello, everybody. Not sure who is here, but I would say, we would start. Hi, Christina. Hi, Neil. Neil, I would like you to moderate this. I'm going to concentrate on creating, um, a series of pictures that tell a story about the patient. If you have my cell phone, please text me if there are important questions. I have the list of the chat here, but I might be missing that. So don't hesitate to text me if you think there's an important question that I don't miss a good question. So I'm going to start with a clinical story, but then we turn around and look at some things together. So just bear with me, and I see Dr. Coach is here, and we have lots of familiar names. So everybody, welcome. So, the story is about an elderly lady who is 74 years old, had a minor fall, not a very big fall, and but then right after the fall, start having very severe axial thoracic pain. Now, obviously, the first thing in a situation like that, acute pain after a fall, which requires a ER visit, the first thing we do is a neuro exam in a situation like that. The neuro exam, with that we mean what's a motor exam, especially after a fall that includes thoracic pain. We have to pay attention to all the nerves below the thoracic spine. I have a dermatomal kind of map behind me, but if you're in medical field, you should be very familiar with that. When we have a thoracic injury, we have the nerve cell, the first motor neuron can be involved in an injury like that. So we will be looking for first neuromotor symptoms that include myelopathy, problem with the coordination. And so in this case, practically what it means, you check the motor exam in bilateral lower extremity, you check for hyperreflexia or problem with the coordination. These are the typical myelopathic symptoms. Now, the neuro exam is normal. So only thing we are dealing with is actually practically axial pain. And at that point, they got a MRI, rightfully. I mean, I would have gotten a CAT scan, but they got the MRI. And I'm going to show you first the MRI of the thoracic spine. They as well got the MRI of the lumbar spine, but I'm happy to share that with you as well. But the most of the pain was in the thoracic spine. Let's start with easy thing. In a situation like that, you have a trauma in the elderly, most likely osteoporosis. You want to investigate many areas of the body. If the neuro exam in the cranial nerves are all right, you don't necessarily need to get a CT of the head. But if you have a lack of consciousness, in most of protocols, you do need to get a CT of the head as well. So why don't we start with the full investigation of this patient after a fall? So let's start with the CT of the neck. Okay. So, and I'm going to just bring the CT, post-fall CT of this patient on a screen. I'm just going to, like last time, I put this on my. It's going to take a second for this to center and zoom, I believe, this camera. I apologize, we still need to solve some technical problem here. Okay, here finally. Okay, so let's start the this picture right there. So, first of all, maybe somebody wants to say what kind of picture this is. What kind of picture are we looking at right now? No takers? So is it CT? Is it MRI? Is it X-ray? What is this? Raise the camera a little bit. Okay, here. I think that sort of shows you what you need to see. Now, Dr. Coach is asking why we would prefer CT to MRI. The reason for that is actually, I can give you 5 reasons. Number 1, you can get much faster CT than MRI. You know, if you may be familiar with so-called helical CTs. These helical CTs you can get from toe to head within 3 minutes. You can spin and get the entire picture from all the way from the skull to the toes. And as a matter of fact, a few days ago, I was in one of those new machines in Crookston, and we got an entire CT of the chest in literally 20 seconds. So, and in many trauma places right now is when you hit the door, they practically they put you through the CT from toe to head. It takes about a minute or less. It takes more time to put you on the table and take you off than to get a CAT scan. So that's the most important. If the time has of crucial importance, that the CAT scan is much faster. Secondly, is especially in trauma situation, you know, if you have been in a CT or an MRI room is very narrow, and you can if you have somebody who's intubated, CT has a big donut-like opening. Third reason is that you cannot bring anything magnetic to MRI, whereas you can put somebody with his street clothes in a CT, doesn't really matter. On the medical side, it's important that any kind of bone structure is much better visible in a CT than MRI. And the fifth reason is that a regular CT, people who have come to our previous presentation, they know that the regular grid of the MRI is 256 times 256 pixel, whereas CT has the double. In a regular CT, you have 512 times 512, and that may give you 4 times the density. As a matter of fact, in most of the good CTs today, you get 1024 times 1024, meaning you have 16 times more resolution than MRI. You can find more things that are wrong in that. So I think that's enough to say why I prefer CT in a trauma situation to MRI. But so I think we all agree that we are looking at the CT of the cervical spine. Now I'm just going to read that. So the way I would identify that, I say that this is the CT of the cervical spine in the sagittal view in the bone window. Why is it bone window? And I'm just going to put side by side the tissue window, then you can see what the difference is. This is the tissue window of the same patient, same area. See what the differences are. I'm hoping that you see more of the tissue, where it's black and not much of white soft tissue differentiation here. But on the other side, the bone and the hardware that from previous surgery that you see are like, you don't see much of that. So it is give and take. Now the good news is on a real PAC system, and on a real PAC system, you can change this as you wish. You literally can change this to the point that you can look at the density of the tissue that you are interested in. That includes 2 parameter windowing. Again, we did a video presentation a few months back, and we explained what that is, how you can do that. just I hope my camera can do this with me. Here is the actual PAC system that I copied the data from, and on the corner here you see that windowing and leveling here, adjust, and you see I put it in one area and go across, and I can change the windowing as I wish. So let's go back to our regular thing. So in the bone window, so things that we see, first of all, we see some hardware right here. I hope everybody is able to see this hardware. Patient had the previous ACDF, anterior cervical discectomy and fusion, and if I could go layer by layer through this, but I just guarantee you that, and I'm going to actually maybe just go ahead and do that. This is the actual image on the CAT scan, and I'm going down, up and down, and I look at, so let's go up and down and see what we see. This is occiput, cerebellum is sitting here. These are the mastoid cells, air cells. And one of the things you can see here, if somebody has a head trauma, that there are blood or fluid in this cavity here. That is one of the signs if there is a trauma here. Sometimes the fracture line is very, very fine. Now, you see something here. Now, not sure if it comes out on your window, in your place well or not. I think I have more differentiation on my screen, but you need to know your anatomy. There are some sutures, occipital suture, and so on there that they are not fractured. You need to know a fracture line is very much more straightforward. So if I change the windowing, I might be able to show you. I really want to show you that because often you can confuse a normal suture line with a fracture line. And this camera doesn't really, and I cannot share my screen, but you have to be familiar with that. Now, let's go further down on this patient. And I'm going to go and change the window again to bone window. And here we see the C1 and C2. Obviously, C1 is just almost a ring, and this is the odontoid here. You still see the same cut, some of the actual occipital bone. And now we are getting to the axis. This is the second vertebra. And so in a situation like that, I have to go layer by layer down and make sure that there's not a fracture. Now, something is here. First of all, who can tell me what structure is in this hole here and what is the name of that hole? Any takers? No? So I'm going to just do a little, cover the patient's name because this is, I have patients' permission to share this information, but nevertheless, I want to cover the patient name so I can show you the original pictures. Then we can go up and down on the imaging together. So that structure I showed you is the foramen next to our neck, where this is a foramen, Christina. Do you know what runs in that foramen and what's the name of that foramen? Any takers? Transverse foramina, exactly, Neil. What is in that foramen? Vertebral artery, excellent, excellent. Yes, that is where the vertebral artery is. And now, do you want to tell us what vertebral artery does and a little about the anatomy of the vertebral artery and what does it give, the origin of it and where does it go to and so on? Do you want to educate us a little about that? Let me turn it around now. I want you to now look at the original pictures. I covered the name, even though I have patient's permission. I still covered that so I don't want to have unnecessary information disclosed, but here it is. So, okay, well, one of the vertebral artery come directly from aorta, correct? You want to look it up online and quickly let us know what you think? Yes, one of them comes from subclavian. One of the vertebral artery comes uh, from uh, from aorta. So then they run both of them from C7 actually, and sometimes there are variations. Sometimes they come to C6, but mostly it's somewhere C6 or 7. They come into this foramen next to the um, our bone in the neck, and they run, and then they curve out next to the uh, C1, and then they enter the tentorics, enter the dural place, the posterior fossa, and then they come together, and then they become one. What do we call when the both vertebral artery come together? What do we call that? Basilar artery. Great. Yes, Christina. Now it is okay. You guys can look up online, and now this is how this is about learning. I think things that if you feel free to look up things on Google now. So knowing that, now here in the foramen we see this white thing. So what do you think it is? What can be this white in that foramen? Everybody sees that there is a white half moon shape or half circle shaped thing in the foramen? It could be calcification, it could be arteriosclerosis. Why is nobody saying if it's blood or not? Why isn't it this blood? Well, it is there is a way in the MRI you can go and measure the Hans field. That is again for people who have no blood would be white, Neil, in the CT. That blood could be white or dark in MRI depending on the age of the. That is a really complex thing. We should one day talk only about the diagnosing. No, it's okay, Neil. We should one day just talk about the diagnosing the blood in the MRI, because depending on if it's a desoxyhemoglobin or regular hemoglobin or and so on, and if it's breakdown, depending on the age, blood has a very specific. It can be dark or white in MRI, but blood is white in CT, and that is why sixth reason why for a trauma I always prefer CT to MRI. You don't have a problem to differentiate and distinguish if it's blood or something else. But blood has a value, Hounsfield value. For people who have joined us before, you guys know that the way the CT is produced, every dot here actually has a value. That value for every tissue is specific. So you can measure that. And if I measure that, I am in the bone window, I can very clearly say that this is not blood. This is actually as bone density. So think that our bone density in that location in the elderly is calcification of the artery. So arteriosclerosis is the right thing. So this has nothing to do with the trauma. So let's go down. Now here we see some of the facet. In the trauma, we look for so-called jump facet. This is now advanced course for trauma and neuro people, okay? So do you see like a hamburger bun here? Does everybody see? We call this actually, in the neurosurgery, we call this hamburger sign, like two buns of the hamburger. If you see the two buns of the hamburger upside down, meaning the curvatures are meeting each other, we call that jump facet, meaning that the trauma distracted that joint to a point that it jumped out, and then yes, exactly. Now imagine you put the buns the wrong way together. You would see the same thing here, that the buns are the wrong way, and that would be so-called jumped facet. That's obviously something that neurosurgeons deal with, but you should be able to recognize. That is why we look at these pictures always first in the trauma. So let's see here. I'm coming down, and now you see something very, very here. So what is it? This very dense material right here. Who knows what this is? This is the screw of the metal um, of the screw ACDF, anterior cervical discectomy and fusion. But now I'm going to describe to you something we call halo. I guess you understand what I mean halo here. You see that around that very, very dense screw, there is a dark rim. Now, that dark rim that we call halo, that means there is a small little gap between the bone and the screw. That screw is a little loose. Not super bad, and it's not, too dramatic, but there is some loosening of the screw. I can tell you this loosening of the screw did not happen with the accident, because I see that the edge of the bone is compacted and his bone is building around that. So meaning that this is, again, not related to the trauma. This has been there before. Christina asking, why is there no artifact around it, just and so on and so forth? Very good question, Christina. Why would you say that? You remember we looked at some of those metal artifact that star-wise, you remember we looked at the physics of how it's produced. Why is it that in something like some metals, you have this massive artifact, but you don't have for this metal this artifact, even though it's a screw, it's a metal screw? I think you know the answer to that, Christine. The answer to that is this metal is titanium, it's not steel. If this was stainless steel, you would get a massive kind of artifact from that. Yes, it's titanium. Now let me show you the inside of, so this device is built like a part of that is plastic. That plastic part, you wouldn't see it. To recognize that, they usually put two pieces of metal pin in that plastic. Let me show you that pin. You would see that little pin has more artifact than titanium. Titanium is as strong as stainless steel, but is less dense. For that reason, you don't get this artifact, and that is another reason why it's preferred for implants. So, and now here you see that other screw, the metal part of the cage or spacer of the CDF. So long story short, I'm going down. I don't see the cervical spine. And now we are getting to the thoracic spine, obviously. And here you see the first rib taking off. Now, I'm going to ask you a silly question. How do you know this is the first rib and not something else? Like, why isn't this like clavicle? Why is it first rib? It is a silly question, but just why not? Why isn't, how do, and then second rib, third rib? Christina is asking, are all cages plastic? There are some cages that are plastic, or they're made of a plastic material called PEEK or PEEK. But these days, lots of us we prefer titanium cages. So yeah, I mean, clavicle doesn't connect to our spine, does it? Right? There are only few things connect to our spine, and in that location, only thing that connect to our spine is the rib. So you practically, what I'm telling you, you have to know your anatomy. You cannot do anything if you don't know your anatomy. Now, let's look at we have looked at the CT of the cervical spine. Now we are going to look at the CT of the lumbar spine, or MRI of the lumbar spine. They decided to get the MRI of the lumbar spine. Now, yes, that's correct, Ethan. Clavicle doesn't attach to our spine. It attaches to sternum and to the scapula, correct? Okay. So this is they got the MRI of the lumbar spine, and let's see, what do we see here? Now, first of all, let's identify this. This is the lateral view, which we have a name for the lateral view or side view of the spine in the imaging world. Anybody want to throw the name out what we give to the side view of the spine? I see as well that on your window, this camera flips everything around, so you have this flipped view. It's not perfect, but you see what you need to see. So first of all, we call that the sagittal view, if you are looking at from the side, and you see that in this view, CSF is white. And when the CSF is white, that is typically a T2 view of the spine. So this is a MRI of the lumbar spine in sagittal T2 view. Now, obviously this is skin, this is belly. This big vessel here, and I'm telling you the vessel, I give it to you. What is it called, this vessel? What vessel is this? It seems that whatever that vessel is, around L4, it stops. Here, it stops around L4. What is that vessel? And why does it stop at L4? Again, you have to just know your anatomy. This is aorta, and it doesn't stop. It just bifurcates, becomes the iliac arteries at that level. Usually somewhere between L3 and L4, it bifurcates. No, it is not internal vena cava. And the reason I know it's not internal vena cava, let me show you another view of it. So let's go all the way up. You see the vessel that is usually very, very round, it has much more, yes, it's abdominal aorta. It is round because there's more pressure in it, whereas vena cava can be flattened out because the pressure in the vena cava is much, much less than in aorta, obviously. So if something is very round, very distinct, it's usually an artery. So, Christina, what is the usual pressure inside of the aorta? Practice asking what's the normal systolic and diastolic pressure. Obviously, that is much higher than venous pressure. So our systolic blood pressure is usually somewhere between 90 and 130. Oh, yeah. No, you're fine, Christina. The pressure inside of the vena cava is much less, like somewhere between 8 and 12. Yes. So 10 times more pressure in Christina, you're correct. 120 is a good number and that is the diastolic pressure. That is systolic pressure. That goes up and down, obviously. So it can be anywhere between 60 and 130. And it varies. It goes up and down. Now, I want to put the other picture back because there is something. I want to see if you guys notice any major pathology in this picture. Does anybody notice a major pathology in this picture? And that is a reason you have to look at the picture systematically. You don't jump from area to area. You go with one area, like, obviously, I look at the skin, you look at the bone, you look at the spinal cord, you go back and forth. That is when you sit next to a radiologist, you see they go all the time back and forth, just forth. And you're asking yourself, why the hell are they doing that? Why they go so many times back and forth? Like, this time I'm going back and forth, I'm just looking at the bones. Now I'm going back and forth, just looking at the spinal cord. Then I'm looking at the interarticular space. Then I'm looking at the aorta going back and forth. So you pick up a structure and you go back and forth and you look at the entirety of that structure. So, and in this picture, there is a major pathological finding. Who sees it? Any takers? Ethan? No takers? Here, look at this big hole here. Scar tissue here. Yeah. Would I call it a major pathological finding? Look at this big hole here. Is it a tumor? What is that? That's a small node. So that's very true. Why isn't that what I was meaning, major pathological thing? Because small node is when you were an embryo, you gave, you practically, that was a blood supply to the bone. See, when we are born, I actually made a TikTok about it, Neil, that about how our spine is developed. It's an older thing. When we are developed, our embryology is that we have this so-called like a segmental tissue. Those tissue they give rise to each of our segments, and then at the end they go and become our disc. And at that point, there's lots of vascular supplies, and that vascular supply usually is reversed and they go away. But in many people, there's a remnant, the empty space where that vascular supply was. That's called small node. It has no pathological effect. Usually, it's asymptomatic, but you see it often in people. And sometimes radiologists don't even read it because say big deal, small node. Okay, so this is not the major pathology I was looking for. So who can see this? Still, I'm looking for a major pathology. Who can see it? Okay. What is this? Right there. Yeah, this is the outline of major pathology here. What do you guys think what this is? This is a severe compression fracture of the, let's count it. What is it? 5, 4, 3, 2, 1, T12, T11, T10. Is everybody able to see that? So now we know something is majorly wrong in the thoracic spine. Let's go and look at only the thoracic spine now. MRI of the thoracic spine. And why do I always put the sagittal T2? If you remember, the T2 is called the so-called pathological view or pathological kind of picture. I'm going to put as well for you the regular T1 views, and so you can see the difference. You still see it, but you don't see the CSF. You cannot differentiate when the fracture, if the fracture really pushing on the spinal cord or not. Whereas when I put the T2, you see the contour of the spinal cord, and you can see, even though it comes close to the spinal cord, but there's still enough space in the spinal cord, and it's not severely pushing on the spinal cord. Now, that makes sense why this patient has no neurological deficit, because even though we are dealing with a severe fracture, it's not really causing any severe compression of the spinal cord. Now, I'm going to take just 1 minute to answer any question you have regarding this. Then we are going to talk about that clinic of this patient and what the next step would be if you see something like that. Yeah, that is exactly, that is why we have to look at Ethan, we have to look at the picture systematically to not to miss anything, meaning that you concentrate on one structure and go up and down and look at all related anatomy to that structure. So now, uh, patient is asymptomatic. Patient has only axial pain. So what do we do with this patient? Patient is in ER and you are the responsible provider in the ER. You have to make plan for this patient. What do you do? Actually, the answer to that is very easy. You call the spine surgeon. I know it's a trick question, but if you don't have a spine surgeon, you have to send the patient to a place that they do have a spine. Because what to do with this, it's a little more complex than just what it looked like. If Abbasi is available in your local place. But what I can tell you is that what is the safest things to do until the patient is seen with a spine surgeon. Okay? So first of all, obviously you are going to put this patient on bed rest. You're not going to let this patient walk or do acrobatic or send this patient home. The second thing you're going to do is get a serial neuro exam. Find out, how the neuro exam is developing. Just because the moment patient hit the room or your ER, the neuro exam is good, doesn't mean it has to stay like that. And then definitely you want to put the patient on, depending on the situation, on maybe a brace, like a TLSO, something that keep the patient stable. In some situation as well, you want to put the patient on so-called trauma bed, which is practically a hard bed that doesn't give too much away. I'm going to answer you what the difference between the vertebroplasty and kyphoplasty. Now, but before we do that, now you call the spine surgeon, and spine surgeon comes, and your question to spine surgeon is, what do I do with this? Now I'm going to jump into my role as both vertebroplasty and kyphoplasty, both of them use cement. The difference is not in the material, in what we use, if you use cement or not. I'll come back to that now. And I'm going to put it out there. Why is this patient not a good candidate for vertebroplasty or kyphoplasty? She's a very poor candidate for either of those procedures. Before we do that, let's talk about what vertebroplasty or kyphoplasty is. Vertebroplasty or kyphoplasty, let's start with vertebroplasty. Practically in vertebroplasty, you put a large needle, like a 12 or 14 gauge needle, most of the time 12 gauge needle, that is like a tube, and it's another stylus inside of it. You put it inside of the bone, like through this structure here. Look at that, that's a pedicle. You put it through that, and then you put a monomer. That monomer becomes hard and literally turns into a plastic material and strengthens the bone from inside. And that's what vertebroplasty is. You put very liquidy thing under high pressure. The reason most of us, we don't do vertebroplasty these days anymore, is because you're introducing this material, this monomer, under high pressure, and then it can leak out and cause significant problem. Whereas in kyphoplasty, once you put the needle, through the needle, thick needle, very thick needle, you put a balloon, you inflate the balloon lift up the broken bone, and then in that empty space under low pressure, you introduce monomer that then solidifies. So practically, the difference between kyphoplasty and vertebroplasty, the kyphoplasty is called kyphoplasty because it corrects the kyphosis by introducing a balloon that lifts up And I'm hoping all of you see that we have a hyperkyphosis or jackknifing of the spine here. Is everybody able to see the jackknifing of the thoracic spine, or what we call a hyperkyphosis? So kyphoplasty, remember that it corrects the kyphosis before you introduce the cement under low pressure. And because the cement comes under low pressure, it less has a chance of escaping and causing significant damage. Most of us don't do vertebroplasty anymore. We do kyphoplasty. The result of that, cement embolism can be as well a possibility, but that is much more rare these days than local extrusion. Cement embolus is when the cement gets into a vessel and goes to places it's not supposed to go. So, but why is this patient a very, very poor candidate for vertebroplasty or kyphoplasty? None of that would be a good option for this patient. Well, to do either of those procedures, you need to have enough bone that can contain the material. I can guarantee you there is not enough bone here that there is not a space left here that you can lift up and put material here. So what do you do in a situation like that? What do you do in a situation like this, that literally there is not enough material left there that can show you, yes, we needed some kind of fusion. And now, what kind of fusion would work for a situation like that? Tell me. Any takers? Do we have any spine specialists who can tell us what kind of fusion would be an option in a situation like that? Now, traditional olive is by definition is oblique lumbar interbody fusion. Well, all fusion these days are augmented with metal. So barely anybody does these days fusion without metal augmentation. So I'm going to show you what we used to do for things like that. Cash brace. I don't even know what cash brace is. It was maybe long before my time. So I'm going to show you what we used to do for a problem like this. To show you, I'm going to get my presentation that I go and give a talk about why we are not doing the old-fashioned surgery for this anymore. So in a situation like that, we used to put the patient on the side, then literally cut from one end to the other, do what we call thoracotomy, and then open up, collapse along, then literally take the broken bone out. And again, the broken bone is this bone, and then put something in between, lift it up, and then put screws above and below. This is the old-fashioned standard of care. Oh, yeah. Ethan says he'll check with his boss. Well, check with your partner rather than with your boss. So, and this practically is a standard care. This is an all-day surgery. A thoracic surgeon is with you, or vascular surgeon. You resect a rib or two to just get the access, and obviously you don't put that rib back. So practically, patient after surgery missing a rib or two. Then you put the patient in the ICU for a week or two with a chest tube, and then you're hoping that everything heals. And then after a week, patient goes to regular floor, and then literally, hopefully within 2 weeks, you might be able to discharge the patient to a rehab situation. So very high acuity kind of procedure. A 75-year-old in poor medical thing is not a good candidate, and so you don't do it unless they have truly neurological deficit. You rather them be in pain than doing your surgery, literally, because it's a very aggressive, very high morbidity, mortality kind of surgery. So, and for that reason, many of these patients actually they just they have to live with the pain, and but that's not what we do. We did surgery on this patient, and I'm going to show you some of the pictures of what we did with this surgery, and that all comes back to that new method that we have found that we can do this surgery with a minimal invasive way, with a very gentle kind of retraction of the rib, and then getting access to the disc base, and then putting a spacer and then minimal invasive screws. Okay, so this patient underwent surgery just 3 days ago. I'm not going to take too much more time here, but let me show you what was done for this patient here. These are the pictures of the surgery. This is the AP view. And here you see I'm going first with the what we call Jamshidi inside of the pedicle. This is the pedicle. These are the ribs up and down here. And then get some bone marrow. And then with the neuromonitoring probe, we go to the disc base and then put a small little K wire, Kirschner wire. And then we dilate, we take the bad disc out, and then drill a little there to make sure that we have something the bone can grow. And then we put a spacer, and we put that spacer above and below that broken disc here. You see another series of pictures, and then the second disc. Now I'm going to show you the same thing in the lateral view. I'm going to change that because I don't want to put patients down. Again, I have patient permission, but I'm still going to cover that. You don't have to see more than necessary. Okay. Now, this is the lateral view. And you see again, if you look carefully, you see the broken bone. You see how little bone is left there. So there's no way you can do kyphoplasty for that. But here, you're able to go there and put 2 cages above and below the broken bone. And if you look very carefully, you will see that a significant part of that hyperkyphosis after the second cage goes in is corrected. Here it is. And then the next is we put screws in. So this is a surgery that requires lots of small kind of incision, is much less, has much less morbidity, mortality. But I'm going to show you a picture that we just took right after the surgery. And that is actually this picture. So I'm going to show you a few important pictures now that you should be familiar with. Now, it may not come out on your picture very well, but I think I'm looking at what you are able to see. First of all, this is what we did. We put the 2 spacers and 8 screws and stabilized the spine. We took this picture because patient saturation was dropping. Literally, no, it wasn't too bad. Like the ZAT is usually above 93, but patient had 89, 91 saturation. And when we start, trying to extubate the patient, anesthesia was concerned. So what do we do in a situation like that? We get the chest X-ray. And the chest X-ray shows here, let me make it bigger so you see it better. Okay, who can tell me what is going on? This surgery was 1 hour and I think 1 hour and 17 minutes. Not very long. It would be 1 hour and 17. It would be 2 hours just for the opening in the open old-fashioned surgery. So this is not a very long surgery. Yeah. So who sees what's going on in this patient? First of all, so you know this is flipped. I'm saying you that because usually you expect the heart on the left side, and obviously your picture is flipped. So this is left, this is right. That has something to do with my camera. Okay. So having said that, obviously you see the shoulder joints are repaired. You see the hardware, but that is not what we are looking for. I hope that you guys see the EKG leads, right? And here you see the endotracheal tube. So this patient is still intubated. Are you guys able to see the endotracheal tube? Okay. So what is wrong with this picture? Any takers? Okay. Now, when we are looking, obviously patients, that is dropping. Something, lungs are not being maybe perfused or aerated properly. Yes, you have some consolidation here here is the left side. This is the heart, some consolidation, but that's not what I'm concerned about. I'm concerned actually about the right side. Now, the way I want you to look at that. You make it big and you look at the vascular sign of the lung and you go all the way to the chest on the left side. On the right side, look at that. There is no vascular sign. I'm making it even bigger here. On this side, you do not have vascular sign. Yes, the lung is collapsed, Christina. Very good. How do we call this if the lung is collapsed in the chest? How do we call that? Yeah, the lung is collapsed. Look at that here. This is the lung, it's collapsed. What is this space is filled with when the lung is collapsed? Pneumothorax, exactly. We have a pneumothorax here. Good one. So what's the treatment for pneumothorax? You put a chest tube. I'm going to take a few more minutes, but then I'm going to show you exactly chest tube. Let me show you. This is the chest tube that we place now. And now after the chest tube is placed, look at that. The vascular sign goes all the way to the edge of the bone. So pneumothorax is gone. And the ZAT is getting better and so on. Everybody is happy and so on. Now let's look at the post-op CT of this patient. And let's look at the first of the chest of the so-called long window. So this is the so-called the long window or the soft tissue window. Post-operatively, this is the heart. These are the vascular signs of the lung. And you see the lung is expanded on both sides. Now a little bit of air on the right side. Again, this is the right side. I hope everybody understand the heart is usually on the left side. And then here is the pigtail right there. The pigtail chest tube. It's called pigtail because the end of it rolls, and we call that pigtail. Now, for people who are familiar with the MIS DTIF, our approach is from the left. So we don't ever, so on the left side, it's about 5 to 10% of the people have pneumothorax. But this patient has pneumothorax on the right side. So this is not the air coming from outside. Because on the left side, when we do our surgery, we poke a hole in the chest. If you remember that, the one that I showed you how we do the surgery, we poke a hole in the chest, right in the posterior axillary line. So there's sometimes it sucks some air in, and then this is the skin incision look like in my surgery versus the thoracotomy and so on. But obviously, the approach is from the left of the patient, but this patient had pneumothorax on the right side. And what that means for the patient, that this air is coming from the lung itself. Okay, this is a so-called spontaneous pneumothorax. When especially elderly people have start getting intubated and they put lots of air inside of the lung, and that positive pressure can sometimes rupture, so something we call blebs or phlebs. So a small little weak spot in the lung that can rupture can cause pneumothorax. So this pneumothorax wasn't really related to my approach. It was related to inherently partially weak part of the lung itself. But it's an important distinction. You need to know that, because if the air is coming from outside, we close it and we are done with it. But if the air coming from inside, even if you close the skin to the chest wall, that leak continues. And that is what I want you to see that carefully here. So I put the pigtail in, and then I clamped it because I wanted to see if it's coming from lung or not. Lo and behold, again, on your monitor, it may not come out well, but if you make it truly bigger, again, you don't see vascular structure of the lung in the apical places, meaning that after I clamp the pigtail, meaning that I don't suck anything out of it, again, patient develop pneumothorax. So this is a so-called air leak. And then I put the patient back on suction again, and air leak goes away, and so on. So you have to cycle it then through these cycles that you close the. This is a different kind of discussion we should have in the future. How do we deal with the pneumothorax and air leak and so on and so forth? But what you should see from this is you should be able to recognize on the X-ray pneumothorax. That is a crucial, and if you miss it, a deadly problem. I'm sure all of you are familiar with tension pneumothorax and what it means, that when you gather too much air inside of the chest, it pushes entire vascular structure to the other side, and to a point that practically the heart doesn't get enough blood back. On top of that, you cannot oxygenate the blood, and then practically you have a heart failure. This is a deadly problem that you have to recognize and deal with it immediately. Now, cardiac tamponade is something completely different, Nick. It has nothing to do with tension pneumothorax. Cardiac tamponade, who want to tell us what the cardiac tamponade? Yes, cardiac tamponade is when in the pericardium, you bleed in the pericardium. Pericardium is like a sac around the heart, and if you have too much blood there, then your heart cannot empty, get smaller and bigger, and pump the blood out. It can be a fusion, or it can be usually cardiac tamponade is bleeding into the pericardium. So, if nothing, I want you to get this out of this picture. Memorize this picture, engrave it in your brain, and do not miss it. You see the contour of the lung? And you see that there is no vascular signs in the periphery, especially in the apical piece. And if you compare it to the other side, you see the vascular sign, those like a line going out on this side, but not on this side, okay? If you miss that, somebody will die. Do not miss that. Okay. Now, I had everything I wanted to tell you. Obviously, this patient, the surgery was 2 days ago. We put the chest tube right away in. Patient did well. This is one of the things you see in the ER, and it really works. You put the chest tube in, and numbers get better. Patient wakes up, everybody's happy, and so on and so forth. And how to put the chest tube and so on is beyond this conversation. If you're interested, I can go over that, over didactic of that, and how to deal. That's extremely complex matter, but how to deal with the chest tube collection, how to deal with the chest tube. If there's enough interest, we will come back to that. So it's 5 o'clock. We are going to stop, but I take maybe one or two questions. Any question? Then I would like to thank you all spending your afternoon with me. Neil is asking, some students here are interested in emergency medicine. Good. Then Neil, set it up. Let us have one conversation about the pneumothorax and management of the pneumothorax, specifically regarding how to put the chest tube, how to connect it to the collection system, and how to manage it. Okay? So talk to Amanda, and Amanda can help to set up just a presentation for that. I can even maybe bring a chest tube collection system and a pigtail and a chest tube, and I show it all to you over this room. Okay? So you just talk to Amanda. Maybe one of our meetings can be exactly that. And even though it's just emergency medicine, I think you cannot be a doctor and not know the basic of that, because it is such a important fact, important information, and such a deadly problem if you don't recognize and manage it. Okay. Thank you, everybody. You guys have a good day. It was my pleasure again to teach you. We will make this available online. I'll have to go and edit few things out. Accidentally, I had few times the name out there, but I will go and edit it out. But beside that, thank you, everybody, and you guys have a great weekend. Okay. Bye bye.